Beginning with the next topic, and that is features of neoplasia. Now, this is just an introductory portion which will tell you that no matter whichever cancer or tumor you talk about, these are some common features that you're going to get in all of them. Okay, so let's begin. Number one, anaplasia, then rate of growth, then local invasion and metastasis. Let me just tell you the one-liners quickly and then I'll go into the details. If someone asks us what is the hallmark feature that you have for malignancies or what is the hallmark of this chapter, and that is going to be the anaplasia. Next, if someone asks you what is the sure shot sign, the sure shot or a reliable sign for malignancy means if you get this sign, you are very confident that it is definitely cancer. So reliable sign of malignancy is going to be metastasis. It is understandable also. If you know something has spread out to different parts of the body, do you have any doubt that is it a cancer or not? Of course, you're very sure that if it has spread to different parts of the body, it is definitely a cancer. So this is the reliable sign, most reliable sign. Whereas if they ask you, what is the second most reliable sign? And there your answer is going to be local invasion. I hope everyone's understood these basic one-liners. I'm going to go into their details, okay? So let's start. We start with what? The first one is going to be anaplasia. What is anaplasia? In simple terms, if I tell you what is the definition, anaplasia refers to loss of differentiation. So now I always, tell the students that sometimes we end up telling you a definition which is tougher than the real word itself. So first we did not know what is anaplasia. Now I've told you loss of differentiation. We don't even know what is differentiation, so how will I understand anaplasia? So first, I will have to explain to you what is differentiation. When that differentiation will be lost, then we'll come to anaplasia, right? So what is differentiation? It's a very basic thing if you think of yourself and your parents. Do you look like your parents? Of course, genetics matters. So your face, your overall appearance is very similar to some of your family members. That is structural, physical similarity. As you will grow older, you will realize that you are behaving also a lot like them, right? So do you also have a behavioral similarity with your family members? Yes. So that is exactly, this means you are differentiated. When I said you are differentiated, I mean to say that you look like your parents, you behave like your parents, means you are differentiated, means everything is good. But if you stop looking like them, if you stop behaving like them, then I'll be a little worried. Why are you not looking like them? Why are you not behaving like them? Then I'll start thinking that why is that happening? And that not looking and behaving like them is known as anaplasia. So if you've understood that story, now let's understand what is differentiation. Forget yourself, come back to tumors. So what is differentiation? Remember, differentiation is defined as the structural and functional similarity. The structural and functional similarity of a tumor to the parent organ, which means what? Let me give you an example. Of, say, for example, there's a tumor in the liver. There's a tumor, let me draw one tumor. There's a tumor that is happening in the liver. So what do you expect? Should the tumor look exactly like the liver cells? Yes, there should be structural similarity. Similarly, should the tumor behave like the liver? What does liver help in? Liver helps in all the bile conjugation. So the tumor also do that? Yes, functional similarity. So tumor should look like the parent organ. Tumor should behave like the parent organ. That is known as structural and functional similarity. But now when I'm saying that structural and functional similarity is lost, when this entire situation is lost, means now the tumor stops looking like the parent, stops behaving like the parent. That is what you refer to as the anaplasia. So simple. What is anaplasia? Loss of differentiation, not looking like the parent organ. That is anaplasia. And like I told you, this is defined as the hallmark feature. So before I go into the details, we had a pact, right? In our general path, we have a pact that whenever we get something like a hallmark or a CD marker, we sit down and revise all the lists. So remember, when I'm talking about hallmarks, please note the first hallmark that I will ask you was, what was the hallmark of way back in chapter 1? That is hallmark of apoptosis. So remember, I hope you do nuclear chromatin condensation. But if I change the question, what is the hallmark of neuronal apoptosis? Neuronal apoptosis was working different, right? So neuronal apoptosis is going to be activation of apoptosis inducing factor. Can you recall apoptosis inducing factor? Number 3, I had asked you what is the hallmark of Barrett's esophagus. There were some cells in Barrett's esophagus that you had to know. Those were the goblet cells. Next, coming to the inflammation chapter, there were 3 hallmarks over there also. So quite many hallmark lists that we have. What is the hallmark of acute inflammation? What is the hallmark of chronic inflammation? And what is the hallmark of repair? These were the 3 questions. So tell me guys, what is the hallmark of acute inflammation? Increased vascular permeability. What is the hallmark of chronic inflammation? In chronic inflammation, everything was getting destroyed. So tissue destruction. And if destruction will occur, then repair will occur. Which tissue was the hallmark of repair over here? That was the granulation tissue. So well, having said that, these are the 6 hallmarks that you have done up till now, and I hope you all could recall them, which would be a good sign of you going ahead with pathology, because now I add the 7th hallmark, which is anaplasia. So now you have to know little bit details about anaplasia, but I'm sure one more term is coming to your mind, which we had left in the first chapter, and I told you I'll teach you when we come to the neoplasia chapter, and that is dysplasia. So what is the difference between dysplasia and anaplasia? So first and foremost, let's make you understand, like if you were a non-medico, or if a non-medico friend of yours asks you, what is this dysplasia? What is anaplasia? You should be able to answer. So in very simple terms, guys, please remember, dysplasia is pre-cancer and anaplasia is cancer. Anaplasia is cancer. So when someone gives you a report, and you will very often as a medical student get all those WhatsApp reports, which I'm sure you get even from your first day of MBBS, where everyone believes you've entered MBBS, so you've become a doctor already, and you can read all the CTs and MRIs and reports. So they send you biopsy reports and they say, what is the doctor, what is the pathologist written? Dysplasia, anaplasia, what is the meaning? You should be able to tell them that dysplasia means pre-cancer and anaplasia means cancer. So now, before I go into the differences, I want to tell you that what are the common points between them? What are the common features that anything, so whether someone has just started with cancer means pre-cancer, or someone has proper formed cancer, either ways there are some 5 common features that everyone is going to have. The first one is going to be loss of polarity. What do you understand by loss of polarity? No one can give you a definition for that, so I'll try and draw a diagram. For example, this is some epithelium. I'll draw that epithelium over here, right? And we'll draw it many layers. For example, it's the skin. It's got many layers of epithelium. Now suddenly, look at what has happened. Whenever some cancerous change starts, is the arrangement orderly? No, the architecture is lost. See how it's all become haphazard. There's one more definition of polarity. They say that the nucleus should usually be towards the basement membrane. The nucleus should usually be towards the basement membrane, but when that will be lost, the nucleus will be anywhere. The nucleus will be up, down, in all random locations. So basically the word loss of polarity means randomness is coming. The nucleus is going at all different levels, the cells are going at all different levels, total chaotic situation has happened. That is loss of polarity. The second thing that you need to know is there is something known as pleomorphism. There's a definition. So first I'll tell you the definition. Pleomorphism means that there is a variation in the size and the shape of the cells. Variation in the size and shape of the cells. That basically means that some cells are going to be small, some cells are going to be huge, some cells are going to be a little medium in size. Then some cells are going to be round, some cells are going to be spindled, some are going to be polygonal. So all sorts of sizes, all sorts of shapes you will get, and that is known as pleomorphism. Coming to the third one, which gets you the maximum questions, that is, all cancerous changes will show you increased NC ratio. So you first need to know what is NC ratio. So first I'll tell you a normal. So let us draw a cell. For example, if this is a cell and I always draw a pink color cytoplasm, inside that I always draw a nucleus. Or we'll draw this as the nucleus. So how much of nucleus area have I taken and how much of cytoplasmic area have I taken? So they ask you, what is the nucleus is to cytoplasmic ratio? What is the nuclear to cytoplasmic ratio? And here I'm talking about a normal cell. In a normal cell, the nuclear cytoplasmic ratio is going to range from 1:4 to 1:6. Very famous previous year question. You will see this many a times. So 1:4, you can see it's only gathering probably one part. From 1:4 to 1:6, the nucleus is smaller, right? Obviously. So 1:4 to 1:6 is the usual range of the ratio. But when we are talking about a cancer cell, do you know what happens in a cancer cell? You will suddenly realize, look at the changes. The cell is the same, it's the same cell, but what has happened to the nucleus? What do you think has happened to the size of the nucleus? Has the nucleus become very, very big? Almost as much as the cell only. Can I say in a cancer cell, there is the increase in the nuclear cytoplasmic ratio almost becoming 1:1? Can we say that? In a cancer cell, it is becoming almost 1:1. So these are the two questions. The normal NC ratio is 1:4 to 1:6. That's a range. And the cancer cell more, see why cancer cell has more, why has the nucleus become so big? Because guys, think logically, cancer dividing non-stop, dividing 24/7. So the nucleus is going to become very big because of overactivity. I don't know how many of you noticed, but I will make you notice now. Not only did I change, but I changed one more thing. Did I also change the color? Initially, look at the color of the nucleus was a little light blue. And then when I made a cancer cell, I made a dark blue color nucleus because that is going to be your fourth point. Your fourth point is hyperchromasia. Or what do you mean by a hyperchromasia? Hyper means something is going to be more, and chromatin. Chromatin is where? Chromatin is in the nucleus. So there's going to be more of blue color because there is more of chromatin. So whenever we say hyperchromasia, means the nucleus is having too much of chromatin. Too much of chromatin means too much of blue color is going to be there. I hope we've learned the 4 points because the fifth one is pending. And let me tell you, these are going to be there in dysplasia and in anaplasia, pre-cancer and in cancer. So number one, everything is going to be haphazard, loss of polarity. Second, all sorts of shapes and sizes, pleomorphism. NC ratio increases. How much does it become? Almost 1:1. The nucleus also becomes very, very blue. And the fifth thing and the last thing that you have is going to be mitosis. Now you can see what is mitosis. Mitosis means that the cell is dividing, right? So when we say mitosis, you can see how the cell is dividing. It's looking like a sunburst. Actually, there are, pathologists by now, pathologists love their imagination and giving weird names to things, right? So this is known as a sunburst mitosis because it looks as if, there's a full sun ray kind of an appearance. This is a sunburst mitosis. This is a very interesting mitosis. The chromosomes are dividing. It's looking like the Mercedes-Benz sign. Yes, so there is a Mercedes-Benz sign, a Merck sign, which this mitosis is showing you. Yes, so remember, mitosis just signifies division of the cells, and that division of the cells will be seen whether you're talking about a pre-cancer or a cancer. These are the 5 common points. So is something coming to your mind? When everything is common, how do you differentiate? How does a pathologist differentiate whether the person is in pre-cancer or cancer? Because surgeon actually wants to know that. Let's come to the brutal reality, and that is surgeon is not interested in these terms of the pathologist. Pathologist is writing this for his own satisfaction. Surgeon wants an answer to a simple question. Are we in pre-cancer? Then my treatment is different. Or are we in cancer and I should give chemotherapy? My treatment is different. So the surgeon is just interested in knowing the difference between the two rather than the similarities. So what I'll do, I'll draw a basic thing which everyone is aware of. And what is that? The basement membrane. No matter whatever cell that you may be talking about, everything is going to be present finally on a basement membrane. So let us draw some cells. These are the cells, all random, big, small. These are all big, small cancer cells. How do I know? Are they pre-cancer or cancer? So please remember, if the basement membrane is intact and all the cancer cells are above it, so if the basement membrane is nice and intact, we are in the pre-cancer stage. This is going to be a pre-cancerous situation. Whereas as soon as, now think logically, as soon as the basement membrane is going to break, we are going to create a break over here. As soon as there is going to be a breach in the basement membrane, that is how it's written in the questions, guys. The basement membrane is breached. Basement membrane breached means basement membrane is broken. As soon as the basement membrane is broken, all these cancer cells will then roam around to different parts of the body, which means we have now entered into the cancer stage. So that is what I look out. Now, if you ask me what as a pathologist do you look out for? I look out for the basement membrane. If the basement membrane is intact, it's in still there's hope, there's pre-cancer. But as soon as the basement membrane is open, is breached out, is broken, it's going to be a definitive cancer. So this is a very famous previous year question, that how do you differentiate between the two? Now, another question must be coming to your mind is that I also had one more term which was metaplasia. So now I've got all three terms in one place and you have to tell me the differences between them. So what was their definition? First, tell me the definition. Metaplasia was one tissue changing into another tissue. Do you remember from your first chapter? One tissue changing into another tissue, that was metaplasia. Okay, what is dysplasia? Dysplasia in simple terms is pre-cancer. And what is anaplasia? The loss of differentiation. In simple terms, it is cancer. Now they ask you which is reversible, which is irreversible. So think logically and think of the question that I told you a million times. Metaplasia is 100% reversible. That is the reason we used to draw that arrow also in that manner, that metaplasia can always be reverted. It is 100% reversible. Think logically, cancer. Is cancer reversible? If you don't give treatment, is cancer going to go okay, is going to become okay on its own? Of course not. Cancer is going to be irreversible. Cancer is going to be irreversible. Whereas what about pre-cancer? Now that depends. This depends on the patient. If the patient has come to you at an early stage, I can help him. Things can go back to normal. If the patient comes at a later stage, I cannot help him. So can I say this depends on the patient? So I will call it partially reversible. Means if it comes at an early stage, I can revert it. If it comes at a late stage, I cannot. So it's partially gray zone. And these are the next set of important PYQs that you have. Which is reversible, which is irreversible. Repeating, metaplasia is always reversible. Cancer is always irreversible. Dysplasia, the pre-cancer zone, that is kind of in between, partially reversible. Before we end the discussion of these topics, I think we'll quickly cover up what we study in cervix also. I think the concept of pre-cancer or the concept of dysplasia is maximally going to be covered in gynecology and cervix. So let's correlate it with our gynae aspect. So let's say pre-cancer or dysplasia, and in the cervix, you call this as CIN. What is dysplasia also known as? CIN. So let's write the full form. It is cervical because we are dealing with cervix. Intraepithelial. Why are we saying intraepithelial? Think of your logic. Everything is happening inside the epithelium. Why? Because you are dealing with dysplasia. Has the basement membrane broken? No. You will actually see all throughout the basement membrane is intact. The basement membrane is intact. The basement membrane is intact, because this will tell you that, okay, yeah, the basement membrane is intact means I'm still in the pre-cancer stage. I'm still in the dysplasia stage. So CIN is cervical intraepithelial neoplasia, that whatever is happening in the epithelium. The basement membrane has not broken. So we further divided into CIN 1, 2, 3, which you must have heard of, right? So please remember, when we talk about CIN 1, then CIN 2, then CIN 3, and then following CIN 3, we have something called CIS. So these three terms I have to fulfill and I have to make you understand. What do I mean by CIN 1? Dysplasia grade 1. Whatever changes are there are only in the lower 1/3 of the epithelium. Remember, the lower 1/3 of the epithelium is going to show you dysplasia. The lower 1/3 of the epithelium shows you dysplasia. Okay. When I say CIN 2, it is the lower 2/3 of the epithelium which is going to show you dysplasia. So it becomes easy to learn now. 1 for 1 and 2 for 2 means in CIN 1, how much third? 1/3 of the epithelium, lower 1/3 shows you a problem. In CIN 2, 2 for 2, the lower 2/3 is going to show you a problem. In CIN 3, 3 for 3, 3/3. What is 3/3? 3/3 means the full epithelium, almost the full epithelium is going to show you the problem. So can I say almost full thickness? That word is very important. Almost full thickness is going to show you a problem. Almost means from here from here all the way up, almost. I've not included the topmost layer, I've said almost. Because now when I say finally, the full thickness is covered. So I will mean that from below all the way up till the top, when the full thickness is covered, that is CIS. And what is CIS? All of you already know the full form of CIS. CIS means carcinoma in situ. In situ means it's still inside. See, I still haven't gone into proper cancer. Inside means the basement membrane is still intact. And this is known as carcinoma in situ. So let's do a recap. CIN1, 1 for 1, the lower 1/3 has a problem. CIN2, 2 for 2, the 2/3 has a problem. CIN3, almost 3 by 3, almost the full thickness has a problem, because when entire full thickness will have a problem, I will call it carcinoma in situ. And look at the last picture, guys. In the last picture, I realized the basement membrane is looking broken. If I'm saying that the basement membrane has broken, are you still in precancer? Are you still in dysplasia? No. Then I will call it cancer. This is anaplasia. This is anaplasia, or this is cancer that has occurred over here. So everyone needs to remember this, and I hope you will learn it exactly like this, because the same concept will help you a lot when you go to your gynae chapters. Okay, having said that, coming back to the features, I hope you all remember you had to cover a total of 4 features, right? So let's have a look at it. Number 1 is done, that is anaplasia. Now we move on to the second one, and that is rate of growth. So this is a common sense kind of a feature. I never want to teach it also, only for, you know, just quick formality we are going to study. I just want to ask you a common sense thing. If you are dealing with a non-cancerous tumor versus you are dealing with a cancerous tumor, which one do you think is going to have a greater rate of growth? Which is going to proliferate more? Obviously, the rate of growth will be more for cancerous tumor and lesser for benign tumor. Do you have to learn any of this? Obviously, it's common sense. Non-cancerous will have less proliferation, cancer will have more proliferation. This is not a question they will ask you. They will ask you 2 very logical and 2 very logic, but also a little bit of mugging up. So they will ask you, what is the minimum weight of a tumor that you need to have for clinical detection? Means the radiologist should be able to see it on an ultrasound, or the clinician should be able to catch it. So remember, for clinical detection, the minimum weight is 1 gram. Remember, the minimum weight is 1 gram, and 1 gram of tumor corresponds to how many cells? You might feel 1 gram is nothing, but this is 10 to the power 9 tumor cells that are going to be there. Imagine just 1 gram of tumor has 10 to the power 9 cells. So if you've learned the minimum, this much of tumor you need to have, only then will the doctors and the radiologists be able to pick it up. And if you've done the minimum, you will also do the maximum. What is the maximum weight of a tumor which is going to be compatible with life? Means that is going to be after this the person cannot survive. This is the upper limit, maximum weight, and that is going to be 1 kg, and 1 kg is 10 to the power 12 cells. So simple, most to learn. The minimum is going to be 1 gram, the maximum is going to be 1 kg, minimum is 10 to the power 9 and maximum is 10 to the power 12. So simple, 1 gram, 1 kg. That is all that you had to know in this particular part. So second feature is also done. What was the third and the fourth feature, if you remember? That was local invasion and metastasis. And do you remember the one-liners? What was the most reliable sign? The most reliable sign of cancer is going to be metastasis. And the second most reliable sign is going to be local invasion. Now I'll tell you the definition. So first, think of yourself. You just decide that you want to go on a vacation, okay? So you have very limited time. You have only 1 or 2 days and you have a very limited budget. You are going from the hostel, so you guys have saved up on money. You said, okay, in 1 or 2 days and with less money, we can only go till somewhere which is say 100 or 200 kilometers away. That is the budget and the time that we have. So what are you doing? You are going somewhere very close to your neighborhood. You are going somewhere very close to your neighborhood, so that is going to be local invasion. On the other hand, just imagine that now you have cleared NEET PG, you have done your MD, you have done your DM, you've become a practicing doctor, and now you have a few days in hand. That is what you feel, but you'll never have that. But you have a few days in hand and you have a considerable budget also. So now you say, I want to go on a foreign trip. I want to go on a foreign trip means you're going for metastasis. Means whenever someone is roaming around in the neighborhood, that is local invasion. And whenever the cancer says, I want to go all the way to the brain, or I want to go all the way to the sacrum, all the way down. So basically it's going to distant places. That is going to be metastasis. So remember, local invasion in local neighborhood, and metastasis is going to be a distant spread. So local invasion is local traveling and metastasis is foreign traveling. So now it's obviously understood that if you don't treat any cancer, all the cancers are going to show you metastasis. All the cancers are going to show you metastasis. Who doesn't want to go on a foreign trip? Of course, all the cancers will go to everywhere in the body, but there are two people who say that, no, I don't want to go on a foreign trip. I want to roam around in my local. There are always people, and all of us, we like roaming around in India more, right? So there are always going to be people who will say, I want to roam around in my local vicinity only. Those two tumors are going to be, number one, basal cell carcinoma. I hope everyone remembers basal cell carcinoma is a very important tumor that you have in the skin, and it is also known as what? Rodent's ulcer. Very important surgery question. What is the other name for basal cell carcinoma? Rodent's ulcer. That is one exception, and the other exception is brain tumors. And what is the name? What is the more logical name of a brain tumor? Glioma. So I have learned that the two B's and B's, they say that I want to roam around only in my local environment. I don't want to go to distant places. I want to roam around in my local environment only. So I'll give you one clinical correlation also with this. You guys must have read about basal cell carcinoma in dermatology also and in surgery also. Where does this occur? The very common site of it is somewhere over here near the medial canthus and the nose. This is a very common site where it tends to occur, right? Now you must have read that from here, it's never going to go to the brain, or it's never going to come to the lungs and the liver. From here, it keeps on spreading on local. It keeps on spreading on the face like a rat. Like a rat, why do you call it rodent? Have you seen rat always keeps on eating that place and makes it hollow? So rat is going to, like a rat, it is going to eat everything and the entire face gets destroyed. That is what you need to know about rodents. That is why they ended up calling it a rodent's ulcer, basal cell carcinoma. So that is how you analyze that, okay, now correlate with surgery, that this is not a tumor which wants to go to the brain or the lungs or the liver. It doesn't want to show me any metastasis. It wants to roam around only in the local environment, only on the face. Same way, brain tumors. Brain tumor grows only in the brain. Brain tumor never wants to come down into the liver. Brain tumor wants to roam around only, spread around only in the brain. So remember these two exceptions. Take home message. All cancers will want to go on a foreign trip, that is metastasis, but the two B's don't want to go on a foreign trip. Basal cell carcinoma and brain tumors, they show you local invasion. Having said this, now if you have to go on a foreign trip, if you have to metastasize, what are the pathways? What all will you do? Like you go in an airplane, or you go via what mode of transport? What are the pathways of going on a foreign trip, that is metastasis? Remember, there is a lymphatic spread, hematogenous spread, direct seeding of body cavities, and transcoelomic. That is exactly what you'll study in the next 15-20 minutes. So first, I'll start off with the two which are the most important. So let me teach you. Number one, we have something known as lymphatic spread. That is, the cancer says I want to go into the lymphatic channels. That is lymphatic spread. The second one is going to be hematogenous spread. Fine. Having said that, now for common sense, when I say lymphatic spread, you guys have understood that we are going to go into the lymphatic channels. But when I say hematogenous spread, so hematogenous spread means what? Arteries and veins. So a very common question comes, what is commoner? Will the cancer go more commonly in the veins, or will it go more commonly in the arteries? So veins are easier to get inside. Why? Let me draw a diagram. This is the diagram of a vein that I have drawn, and this is the diagram of an artery that I have drawn. Tell me which of them has a thicker wall. Obviously, this is common sense. Arteries are having a very thick wall. So imagine going through a very thick wall is going to be really difficult. On the other hand, veins are thin-walled. Veins are thin-walled. So is it easier to go through it? If a cancer cell says, I want to enter into a vein, it's so easy. It has a thin wall. It'll easily go through the thin wall. But if the wall is very, very rigid, can the cancer cell go through it? It cannot. So remember, why are your veins more commonly affected? That is because the veins are thin walled structures. Now, I'm going to tell you some rules over here and then I'll tell you some exceptions. Please remember, all the carcinomas are going to go in which particular route? All carcinomas go to the lymphatic route. And the next rule is that all the sarcomas are going to go into the hematogenous route. So simple. If I say squamous cell carcinoma, when I'll use the word carcinoma, means squamous cell carcinoma will go into the lymph nodes. Whereas when I say osteosarcoma, sarcoma means it's going to go into the blood vessels. But do we always follow rules? We don't. We are always rule breakers. And that is exactly what I'm going to come to. So please remember, I just told you that all the carcinomas are going to show you lymphatic spread. But now I'm going to tell you certain exceptions which will help you. Examiner is always fond of exceptions more than rules. See, rules are something that will help you in clinical practice more, but exceptions are something that examiner will ask you in MCQs more. That's the sad reality. Okay, so when I say except, remember RCC, renal cell carcinoma, HCC, hepatocellular carcinoma, and there's a cancer of the thyroid that you should be knowing, that is follicular carcinoma thyroid. Follicular carcinoma thyroid is what you should be knowing. These three, now I'll repeat, they have the word renal cell carcinoma, hepatocellular carcinoma, follicular carcinoma. I read carcinoma, I think of lymphatics, but no, they are the opposite. They are not, despite being cancers, they are going to show me hematogenous spread. I'll give you some examples. Like if I say renal cell carcinoma, you expect that it should go into some kind of lymphatic carcinoma, but it goes into renal vein. It goes into a vein, it goes into the blood vessels. So these are cross connections. RCC, HCC and follicular thyroid cancer don't go into the lymphatics, they go into the hematogenous. Similarly, please remember, what was going into hematogenous? Usually all the sarcomas are going to go into the hematogenous, except there are a lot many, but I want you to learn the two main ones. And these are going to be rhabdomyosarcoma and synovial sarcoma. Synovial sarcoma and rhabdomyosarcoma, they tend to go into opposite. See, they are sarcomas. I expected they will go into the blood vessels, but they go opposite. They go into the lymphatic channels. They go into the lymphatic channels. So repeating once again, all the carcinomas go into lymphatics except RCC, HCC and follicular, they go into blood vessels. Similarly, all sarcomas go into the blood vessels except rhabdo and synovial. They are going to go into the lymphatic channels. Now, out of all of this, before I proceed on to the other pathways, there is a surgery concept that I want to tell you with regard to lymphatic spread. And that is the concept of a sentinel lymph node, on which we get a lot of questions nowadays. Please remember, sentinel. Sentinel word means the first. Sentinel means first, and lymph node is obviously lymph node. So what is the sentinel lymph node? It is the first lymph node to receive the lymphatic drainage of an organ. The first lymph node to receive lymphatic drainage of an organ. So let me give you an example, guys, which is very commonly used in surgery. For example, I'm not talking about any cancers, okay? I'm only talking about a normal. Normally also we have lymphatic flow, right? So for example, this is the breast and this is the axilla. That is how you draw breast and axilla in surgery. Now just think of a normal breast. Normal breast, the first lymphatic drainage goes to which lymph node? The first lymphatic drainage goes to the axillary lymph node. Can I say that axillary lymph node is a sentinel lymph node for the breast? It is a first lymph node where the drainage is going to go. It is the sentinel lymph node for the breast. Yes? So now put your logic. If normally the lymphatics go first to the axillary lymph node, common sense that if a cancer ends up occurring over here, that will also first and foremost go to the axillary lymph nodes only. So if I know the normal, I'm using that property to get myself into some surgery aspects, which means that when a surgeon is doing a modified radical mastectomy, when the surgeon is trying to remove the tumor and remove the breast tissue, which is the first lymph node that he has to check, and that lymph node will be the axillary lymph node. If the axillary lymph node does not have tumor, for example, axillary lymph node does not have tumor, is there a chance that the other lymph nodes will have the tumor? No, it's like obviously first place, it will first go to axilla, then it will go to the rest of things, right? So first and foremost, you will go to the place where you had to go, and first you will crack your NEET PG or your FMG or your INI-CT, and after that you will think of rest of things in life, right? Can you think of all the good things in life without cracking this exam? Not happening, right? You can't skip this step. So it's obvious, you will have to prioritize. You will first have to go to the area where you have to go, the first lymph node, and then you will go to all the good things in life. But sometimes we always have some people who are lucky and who can use shortcuts. And what does that mean? What if the sentinel lymph node is skipped? What if the sentinel lymph node is not involved? Imagine someone did not clear NEET or FMG and straight away started having fun in life. Straight away started having the good life. Really lucky person, right? But that is what I want to tell you. Sentinel lymph node is skipped and the other lymph nodes are having cancer. Other lymph nodes are having cancer. What do you call it? We call it skip metastasis. This condition is referred to as skip metastasis. Why would this happen? Why is it not when there's a route decided, when it had to go first to the axilla and then to other lymph nodes? Why didn't it go to axilla and directly went to the other lymph nodes? Because there's a roadblock. Someone has blocked this road over here. Why has that happened? So you must have seen in surgery, before you do a surgery, sometimes do you give radiotherapy before the surgery? Can there be radiotherapy induced fibrosis? There is a radiotherapy induced fibrosis that we might have, as a result of which there is a roadblock. Fibrosis means this area is blocked. The tumor cannot go to the axilla. There's a roadblock. The area has been blocked. So it will have to reroute. It will have to go to some other area. So it goes to the other lymph nodes. That is the concept of skip metastasis that you need to know. It's a very rare thing to occur. And when will it occur? When the person was given radiotherapy and that roadblock happened over here. Now, remember the concept of this sentinel lymph node in surgery is not only being studied for breast cancer patients, but is also being studied for colon cancer, for vulval cancer, and for melanoma as well. Colon, breast, vulval, melanoma. Although, surgeons also might believe that we are not doing so much of sentinel lymph node studies, but Robbins has mentioned all of these. This means in different parts of the world, studies are going on. Breast is what is being followed. Obviously, identifying the sentinel lymph nodes as breast is being done in surgeons in our country also. Even for colon cancer, it is being done. But yeah, of course, for vulval and melanoma, also in different parts of the world, this is happening. I hope everyone's okay with these two pathways of spread. We are done with everything to do the lymphatics and hematogenous. Quick review. All the carcinomas are going to go into the lymphatic channels except for HCC, RCC and follicular thyroid cancer, because they are the ones which are going to go where? They are the ones which are going to go as a cross connection. They will go into the hematogenous route. Okay, secondly, I had studied all the sarcomas are going to go into the hematogenous route except rhabdomyosarcoma and synovial sarcoma. They are opposite. Where are they going to go? They are going to go into the lymphatic route. It's a cross connection. Now we move on to the next two. Both of them are coelom. Coelom means body cavity. Both of them are known as body cavity kind of spreads. So let's analyze. The first one is known as direct seeding of body cavity, or this is actually the third pathway of metastasis. So first tell me, what do you understand by a body cavity? What are body cavities? Like what is around the lungs? Around the lungs we have the pleural cavity. What do we have around the heart? Around the heart we have the pericardial cavity. What do we have around the GI organs? So that is what I want to ask you. Which is the largest body cavity? And that is obviously around the GI organs, known as peritoneal cavity. That is referred to as peritoneal cavity. So I will give you examples of the largest only. Okay. So let's say, for example, I'll draw it as PC, that is peritoneal cavity. We'll draw it as peritoneal cavity. And over here, I have a tumor. Let's say we have a tumor. Let's take two examples. Okay. If it's a female, I'm talking about an ovarian mucinous tumor. Giving you two random examples. If it's a female, I'm talking about ovarian mucinous tumors. And in males or females both, I'm talking about appendix mucin tumor. or mucin secreting appendix cancer. Do you see something common in what kind of tumors have I picked up? Mucin secreting. Whether I took up the appendix cancer, that was also secreting mucin. If I took up the ovarian cancer, that is also secreting mucin. Because now all the mucin and all the cancer cells from here, all the mucin and all the cancer cells from here are going to come to which cavity? They can come to the peritoneal cavity. What is this concept known as? This is referred to as pseudomyxoma peritonei. This is referred to as pseudomyxoma peritonei. Now you will understand the real meaning of this word. What is peritonei? Means which cavity is getting affected? Peritoneal cavity is getting affected. Why did we use the word pseudomyxoma? Why myxoma? Because which kind of tumors are coming? The mucin related tumors are coming, right? So pseudomyxoma peritonei means that the mucin tumors are coming into the peritoneal cavity. And remember, they also ask you as a PYQ, what is the most common cause of pseudomyxoma peritonei? That is the appendix tumor. The most common cause of pseudomyxoma peritonei is the mucin secreting appendix carcinoma. Let me ask you a little bit of anatomy. I kept talking about this peritoneal cavity and how it's the largest body cavity, covers all your GI organs, but where does it end? That is going to be example number 2. This was example number 1. Now I'll tell you example number 2. What is the distal point of the peritoneal cavity? It's a test of your anatomy. Distal end of the peritoneal cavity is POD. Pouch of Douglas. So in case you got that answer, pat on your back. In case you did not, still a pat on your back, because you're going to go back to anatomy and quickly revise it, right? Okay, so what is the distal most end we have? That is pouch of Douglas. So if someone says that there is a cancer going into pouch of Douglas, indirectly that person is saying that still the cancer is going into the peritoneal cavity only. And do you know which cancer goes into this? This is a surgery question. Which cancer tends to go into the POD? Gastric cancer. Gastric carcinoma or gastric cancer can go into the pouch of Douglas, and this situation is referred to as Blummer shelf. This situation is referred to as, it's a fancy name. So how have I learned it? Shelf. Shelf means where you finally keep something, and like if you want to, for example, keep this phone somewhere, you'll keep it on a shelf, right? You'll keep it on a shelf. So you rest something. So what is the resting part of this peritoneal cavity? Where is the peritoneal cavity finally coming to a rest, finally coming to an end? That is the pouch of Douglas. So anything goes into the pouch of Douglas, what will you call it? You will call it Blummer shelf. Very famous question, that when stomach cancer, when gastric cancer is going to go into the pouch of Douglas, that is known as Blummer shelf. That was example 2. Let me give you one more example of this situation, which is going to be very, very important. Have a look at this, guys. Have you heard of brain tumors? Of course, if you've read about it, very good. But in brain tumors, you guys must have heard of example number 3. You guys must have heard of something called a tumor as medulloblastoma. Where does medulloblastoma occur? Just a basic thing. Even if you've not read about it, never mind. Medulloblastoma is something that occurs very commonly in the cerebellum. So this means it's occurring in the cerebellum. I'll draw this as the cerebellum. Just imagine the cancer drops down because of gravity. Suddenly the cancer says, I am going to drop down because of gravity. So can I say the cancer cells have come where? Spinal cord. From the brain, they have dropped into the spinal cord. So can I say the cancer cell has dropped into CSF or spinal cord? What do you want to call it? You call this drop metastasis. It's the easiest to learn. If you know its name, it's the easiest to learn. It's known as drop metastasis. So repeating, there are 3 things. This is also a body cavity only, right? CSF and spinal cord is also a body cavity. So when you're talking about body cavity, example number 1 is pseudomyxoma peritonei, because peritoneal cavity. End of the peritoneal cavity is pouch of Douglas, so Blummer shelf. And the third one is going to be the drop metastasis. Brain tumor drops into the spinal cord, so that is going to be drop metastasis. Okay, this was the third pathway of spread. Now I'm going to tell you the fourth and the last pathway of spread, which is transcoelomic. And did you notice something? Coelom also means body cavity. So why do I have two things for body cavity? I'll tell you this pathway and you will see the difference. You know what I'm going to do over here? At one end, I'm going to draw the ovary because that's the best example that you have. So for example, this is the ovary that you have. Other than that, over here, I'm going to draw the other organs. Let's say you have a breast cancer. There's a female with a breast cancer, or there's a female with, a stomach cancer, or you can even have someone with, someone female having a colon cancer, or sometimes even we can talk about pancreatic cancer. I hope that looks like a pancreas. So basically, I'm talking about someone having a breast cancer, someone having a stomach cancer like this, someone having a colon cancer, and pancreatic cancer. These are the 3-4 options given to you. Now the cancer cell says, I want to go and I want to go all the way till the ovary. So for example, I'll take the most common thing that we see in practice, stomach cancer. Stomach cancer cells say, these blue color stomach cancer cells say that we want to go and we want to settle where? We want to go and settle in the ovary. Okay, how will it go till there? It is going to go via which route? It goes via body cavity. It tends to go via the body cavity. So did you see? Trans means what? Transport. Transport is occurring through what? Transport is via the body cavity. Now you understand why I called it transcoelomic. Trans for transport and body cavity is coelom. So transcoelomic. So now what is the difference between this body cavity and the previous one? In the previous one, if you noticed, cancer cells were going and sitting in the body cavity, seeding in the body cavity. They were sitting over there in the body cavity. Here, the cancer cells are not sitting. They are just moving. They are just moving forward. Ultimately, where will they go and sit? They will ultimately deposit where? They will deposit in the ovaries. And you know what is this kind of a tumor known as in gynecology? This is the Krukenberg tumor. This is referred to as the Krukenberg tumor. So repeating once again, if the cancer comes and sits in the body cavity, that is seeding in the body cavity, right? But if the cancer just goes through and through transport and goes and sits where? Goes and sits in the ovary, that is going to be known as transcoelomic or Krukenberg tumor. Although let me tell you, nowadays when you read your latest gynecology textbooks, this has not been added or updated in Robbins, but in gynae a lot of hypothesis is coming up that Krukenberg tumor, this tumor that we have, this is not per se because of transcoelomic, it is because of something known as retrograde lymphatic flow. But again, a lot of hypotheses and things coming up, but Robbins still mentions transcoelomic spread. And that basically wraps up all the 4 pathways of metastasis: lymphatic, hematogenous, seeding, and transcoelomic. Before we end this section and practice a few questions, there are some tumors which will always tend to go into the bone. They tend to show you bony metastasis. So first I'll tell you the mnemonic. Which are the tumors that tend to go into the bone? That is, public toilet tumors tend to go into the bone. What do I mean by that? P is going to be for prostate cancer. P is going to be prostate cancer. There's nothing with U. There is B for, now you'll think of most common things you've heard of. B for breast cancer. L, obviously you've heard of lung cancer. I for intestinal cancer. Intestinal cancer. K for renal or kidney cancer, so renal cell carcinoma in simple words. And T for toilet that we've done, that is going to be thyroid cancer. So repeating, we have prostate, breast, lung, intestine, kidney and thyroid. All these. Public toilet tends to go into the bones. Now which bone? Put your common sense into it. Think logically. Prostate cancer will go to, where is the location of the prostate? Prostate is going to go into the lumbosacral region. It is going to go particularly to the lumbosacral bones. And if I take you back and integrate this with anatomy, tell me that prostate cancer goes into the lumbosacral bones via what? There's a venous plexus, very famous, Batson's venous plexus. It goes into the bone via the Batson's venous plexus. Now, think logically, where will thyroid cancer go? Thyroid is over here, so it will go into which vertebra? It will go into the cervical vertebra. Breast cancer, breast will go into thoracic vertebra, ribs. So whatever is the location of the organ, the bone will be obviously involved as per the location. But the question that they ask you is, once it goes to the bone, let me draw this bone. Although it looks more like a dog bone, but once the cancer has gone into the bone, what next? What after that? So only going and sitting in the bone is not the only criteria of this. After going in the bone, does it make new bone? Is new bone going to form suddenly? New bone will form? Or will it break the bone? So now my next question is, all these cancers, these public toilet cancers, are you going to make new bone or are you going to break the bone? So please remember the first one. The first one that we have, that is prostate cancer, is osteoblastic. What do you mean by osteoblastic? Osteoblast is always going to make new bone. It is going to make new bone, right? On the other hand, the other two are 2-2, means they can be osteoblastic also, or they can be osteolytic. Lytic means that they can break the bone also. So they can either be osteoblastic or they can be osteolytic. They can do either of them. So 2-2 can do 2-2 things. And finally, the last 3, that is intestinal, kidney and thyroid, they are only going to be osteolytic. Lytic means that they are going to break the bone. They are going to destroy the bone. So how have I learnt it? P looks like a B, right? P is going to look like a B. So the first one, the prostate cancer, is osteoblastic. P is going to look like a B. So prostate cancer is blastic. The other 2 are 2-2. So breast and lung are both. They can be blastic, lytic, both. And the last 3 that I'm left with, they are going to be osteolytic. I hope that is okay. That's one flashcard that we've made. Public toilet tells you that these all tumors go into the bone. After that, you get to know that, okay, which of them is blastic, both and lytic. With which we wrap up this introductory section and we are ready for some questions. Here we have a 63-year-old woman with chronic bronchitis, presents with shortness of breath. A chest x-ray reveals a 2-centimeter coin lesion in the upper lobe of the left lung. A CT-guided lung biopsy is obtained. Which of the following describes the histopathological features if the diagnosis is hamartoma? Now, first and foremost, over here the examiner was very kind to us and gave us the diagnosis of hamartoma. But now I want to link this with your clinical aspect. Have we already studied what is hamartoma? Is it hamara tissue or ectopic tissue? Obviously, it is hamara tissue. It is normal tissue. It is not at all ectopic. It is not at all to do with granulomas. It is disorganized normal tissue. It is hamara tissue. But what if the examiner wouldn't have given me the diagnosis of hamartoma? How would I have identified? Let me tell you a clinical dictum which is very famous. You know, hamara word is going to help me a lot. I will read about everything about hamartoma from hamara word. Means what tissue? Hamara tissue. Number 1, it is hamara tissue means native tissue. Also, I want to tell you, whenever you go for movies, especially in college days when you have a money crunch and pocket money system going on. So it's simple. If I will pay for a movie and for the popcorn, then I will eat the popcorn. Simple. So if I am paying, I get the popcorn. So I will say hamara money. Hamara money means what? Money is coin lesion. Radiologically, it is going to show you coin lesion. So if I am paying the money, I get the popcorn. So which calcification does it show you? It shows you the very famous popcorn calcification. So that is how I have learned hamartoma. Hamartoma is everything to do with hamara. It's my tissue, my money, my popcorn. So hamara tissue, hamara money means coin lesion, and hamara popcorn means that is popcorn calcification. Let me ask you a question from radiology. Where else do you see popcorn calcification? There's a breast tumor also where popcorn calcification is noted, and that is fibroadenoma. Very famous radiology question, fibroadenoma. Okay, let's pick up the next question that we have. There's a 50-year-old female who's come with a lump in the breast. A 4-centimeter firm and fixed mass. So firm and fixed in a 50-year-old. I have started thinking of cancer. Okay, that is noted on breast examination. Excisional biopsy shows malignant cells. They've told me it's a cancer with gland-like structures, nests, and surrounded by a dense collagenous stroma. A connective tissue stain called trichrome. Do you remember this stain from your previous chapter? Mason trichrome. We've done it in inflammation. Yes, Mason trichrome is done and that is shown. Do you remember? In Mason trichrome, the basic purpose was to differentiate between muscle and collagen. And for that, I gave you a mnemonic mister, that muscle is going to come out to be red and collagen is going to come out to be blue. So what I see over here is a lot of collagen. A lot of blue color material is seen over here. And they have anyway told me that there is a lot of dense collagenous stroma. Now they want to ask you which of the following term describes the blue areas, collagen. So do you remember the first slide that I taught you in this chapter? Every tumor has two parts. One are the tumor cells and the other is the collagen or the fibrous tissue that we are making. The desmoplasia, that is the host response, that is the fibrous tissue made up of collagen that we are making, and that is what you had to pick up over here. So what started off like a surgery breast cancer question ended up in a general pathology question, and that is exactly what I wanted all of you to analyze. That although your term, the length of the questions and the pattern of the questions might be changing, but your basic sciences and your 19 subjects with diseases remains the same, right? Having said that, I hope you guys have analyzed that this was desmoplasia. Let's pick up another question where you have a 20-year-old woman with an ovarian tumor that has been removed. The surgical specimen is 10 centimeters in size and cystic. The cystic cavity is found to have hair, sebaceous material, and they're all well differentiated tissues including skin, cartilage, brain, glands. Everything is well differentiated, means everything is mature. What is the diagnosis? They had not even asked me whether it's a mature or an immature teratoma. They have given only an option of a teratoma. But yes, I know more knowledge by now that when everything is coming out as benign and mature, the answer is going to be a mature teratoma. Having said that, let's pick up the last question and then we'll move on to the next segment. There's a 45-year-old woman who presents with abdominal pain and vaginal bleeding. So a hysterectomy is performed and shows a benign tumor of the uterus derived from the smooth muscle. This is a very important thing. See, muscle means what? Something myo. And they have said smooth muscle. So what do you want to call it? Neomyo or rhabdomyo? Smooth muscle means leiomyo. And then they said there's a benign tumor. So you want to add the word oma in front of it. So what is the total terminology come out over here? It is a leiomyoma, because leo will tell me that they are dealing with a smooth muscle, leiomyo, and oma will tell me that it's a benign tumor. What are the others? If they would have said cancerous tumor of smooth muscle, then I would have used the word sarcoma. So nahi. If they would have used the word skeletal muscle, then I would have thought of rhabdomyoma, and skeletal muscle is not going to come up in the uterus. Another common sense point. Uterus has smooth muscle only. And myxoma word is totally out of this option, is totally absurd because there is no myxoid word, mucin word is only not mentioned in the question. It's a classical leiomyoma. So you realize of how they will club this section with your different clinical histories. We wrap up all the features that you had to know with all the spreads. Now what do we move on to next is going to be the fundamentals of neoplasia.